Diabetes management. Diabetes is a group of disorders, metabolic disorders, which are characterized by hyperglycemia. That means raised blood sugar levels. So for diabetes management, we have two agents. One is oral drugs and second is injectable insulins. So we are going to study these. So first is oral anti-diabetic drugs. So these oral anti-diabetic drugs are categorized roughly into three categories. First is drugs which overcome insulin resistance. Second is drugs which enhances the insulin secretion from the pancreas. And third is drugs which retard the carbohydrate absorption from the GIT. So if carbohydrates are less absorbed from the GIT, that will result in low blood sugar levels. So these insulin resistance, the drugs which overcomes the insulin resistance are two: metformin and pioglitazones. These metformin and pioglitazones reduces the insulin resistance of the body, thereby the glucose is much effectively used by the body cells, thereby lowering the blood sugar levels. Whereas the drugs which enhances the insulin secretion are of two types: ides and ines. They end with the suffixes of ides and ines. The ides are two sulfonylureas and meglitinides, whereas the ines are DPP4 inhibitors or the gliptins. They are also called gliptins. So these are the drugs which overcome the insulin resistance. Two of them are very important. One is metformin and second is pioglitazone. The mnemonic for this is we met in a zone. So met and zone. Metformin and pioglitazone. Metformin, the maximum dosage is 2500 to 2500 milligrams to 3000 milligrams per day in divided doses. Whereas pioglitazone is generally given as a single dose ranging from 15 milligrams to 45 milligrams. The drugs which enhances this insulin secretions are number one sulfonylureas and number two meglitinides and number three these DPP4 inhibitors or gliptins. So the ides and the ines. Ides are the sulfonylureas like glipizide, gliclazide and glimpride. These are the most important. Glimpride, gliclazide and glipizide. This is glimpride, gliclazide and glipizide. And similarly, meglitinides are repaglinide and neteglinide. These DPP4 inhibitors are gliptins, sitagliptin, vildagliptin are important. The drugs which retard carbohydrate absorptions are alpha glycosidase inhibitors like acarbose, migilitol. So how to plan these oral drugs for a diabetic patient? So as the diabetes is roughly divided into two categories, type 1 diabetes and type 2 diabetes majorly. The type 1 is where the insulin deficiency is prominent and type 2 is where the insulin resistance is the main pathology. So for type 2 diabetes, these oral drugs work because type 1 diabetes patient is dependent on insulin because there is no insulin production or very less insulin production. So they are completely dependent on the insulin, whereas the type 2 diabetes are more dependent on the oral drugs. So these oral drugs are divided into three plans: one drug plan or one drug regimen, two drug plan or three drugs plan. As the name is suggesting, one drug means one drug is given, two drugs means two drugs are given, three drugs means three drugs. So one drug regimen, generally we start with the biguanides, that is metformin. The only biguanide which is presently which is being used is metformin. So metformin up to the range of 2500 milligrams per day in divided doses is given. Generally we start with 500 milligrams per day. We raise it to 1000 milligrams per day. Right, BD in a BD dose twice daily or thrice daily. Right, it lowers the HbA1c, it reduces the insulin resistance, and it is a very safe drug. And the only contradiction for giving metformin is some gastric upset if it is not very much comfortable for the patient to take it, or if the patient is suffering with a kidney failure with raised serum creatinine and lower GFR. So if one drug regimen fails or if the HbA1c levels are very high, then two drug regimens are started initially. These two drug regimens can be of multiple regimens. For example, the drugs which reduces the insulin resistance, IR, IRES stands for insulin resistance. They are given in combination like the MET and the zones. So metformin and the glitazones. Most commonly given combination is metformin and glitazones. However, these glitazones are contraindicated whenever there is a case of heart failure, because glitazones leads to fluid retention, thereby increasing the heart failure uh, chances. So if person is already suffering with some type of heart failures like congestive heart failures, then these glitazones are avoided. So in spite of glitazones, we give sulfonylureas. So now the combination becomes insulin resistance plus insulin secretion drugs, the drugs which secretes the insulin more. So metformin and sulfonylureas. So these sulfonylureas, they have certain restrictions, like they causes weight gain, and even they can cause hypoglycemia, right? So in such cases, instead of sulfonylureas, migletinides are used, but not in a combination, as separate drugs. Third are metformin and gliptins. Metformin are the insulin resistance inhibitors, and the gliptins are the insulin secretions drugs. So the gliptins are given, but these gliptins are comparatively they are costly. One tablet or one dosage costs around 9 or 10 rupees, so it becomes a little costly for the patient. Right. Apart from this, sulfonylurea plus glitazones can also be given, or sulfonylureas and gliptins can also be given either in a combination or as a single drugs. Right, two drugs. So this is the most common combination: metformin and pioglitazone, metzone, gluconom P. P stands for pioglitazones. Similarly, the glimepiride and the metformin, right? Metformin and the glimepiride, the insulin resistance blockers and the insulin secretions. So this is generally marketed as gluconom G1, right? Gluconom is for metformin, and gluconom, when it becomes gluconom P, it is gluconom. It is metformin plus pioglitazone. When it becomes gluconom G1, that means gluconom plus, that means metformin plus glimepiride. So this glimepiride can be given as different strengths, like 1 grams, 2 grams, and depending on the strength, it is G1, G2, G3, 1 gram, 2 gram, 3 grams. Like when the metformins are mixed with gliptins, the combination becomes, for example, this Janumet, right? Metformin plus sitagliptin, or Jalra M, metformin plus vildagliptin. Then let us come to the next regimen, three drugs regimen. If two drugs regimens fails, or if the HbA1c is very high, or if the patient has stopped responding to the two drugs regimen, we change it to the three drugs regimen. In such cases, metformin plus sulfonylureas plus glitazones all together are given, right? Either in combination or as separate drugs, or in spite of glitazones, if the person is having contraindications for glitazones, gliptins are given. Gliptins are very good, but they are little expensive. They are weight neutral. They does not causes the patient's weight to increase as a result of the therapy. So metformin and sulfonylureas or gliptins and insulin. The third drug becomes the insulin is also given in type 2 diabetes. So the cases who are having higher HbA1c, 1AC, they can be given insulin in the starting, and slowly the insulin dose can be tapered off, or it can be stopped altogether, right, with the induction of third drug. So metformin, sulfonylureas and insulin, or metformin, gliptins and insulin. So insulin is given in a regimen which we are going to talk about later. So metformin and insulins, these insulins are of various kinds, like pre-mixed insulins, basal bolus insulins. So we will talk about them in the coming slides. So for example, the three drugs regimen example is glyciphage PG2, right? The P stands for pioglitazones and G stands for glimepiride. Zones are the insulin resistance blockers, inhibitors, and glimepiride's ides are the insulin secretors. So similarly, glyciphage PG2, right? Three drugs regimens. Then let us talk about the insulin therapy. So the insulin was discovered by Frederick Banting and Charles Best. So these Frederick Banting and Charles Best, when they worked on the dog pancreas and found out that certain substance from the dog pancreas is responsible for lowering the blood glucose level, and in absence of pancreas, the blood sugar level shoots up. So they isolated the insulin and they gave the insulin to the world, Manting and West, in the Macleod's laboratory. So let us see what happens historically. So this Sir Frederick Banting and his assistant Charles Best prepared a crude extract from dog pancreas, and this crude extract, the concoction, was called as insulin. So this insulin, when injected into the diabetic rats or diabetic animals, it helped to reduce the blood glucose levels. So later this insulin was commercially made from cattle and pigs. So cattle insulin was called as bovine insulin, whereas pig insulin was called as porcine insulin. So we used this cattle and pig insulin for a very long time, but nowadays it is no longer used. So in 1930, Sir H.C. Hagedorn. Now this insulin has a very short T half life, ranging to few minutes. So in order to prolong the action of the exogenous insulin, Sir H.C. Hagedorn uh, made some chemical which is called as neutral protamine hagedron, NPH. This neutral protamine hagedron is a group of amino acid which, when added to the insulin, increases its action, increases its time duration. So this neutral protamine hagedron was discovered, right? So neutral protamine hagedron was added to the insulin, right? Some other molecules like zinc was also added to the insulin in order to increase its duration. So this neutral protamine hagedron, or it was also called as isophene. So when it was mixed to the insulin, the newer insulin was called as NPH insulin or isophene insulin, the insulin which has longer duration. In 1978, we used the DNA recombinant technology and put the human insulin gene inside the bacterial DNA, and that bacterial DNA was used to collect it. It made insulin, and we used to collect the insulin from these recombinant bacteria. So this insulin was the first time when we collected the human insulin. So the insulin which was prepared from these bacteria, recombinant bacteria, are called as, these insulin was called as human insulin, or more appropriately the artificial human insulin. So it was called as regular insulin or soluble insulin or neutral insulin. In 1996, for this human, we prepared human insulin and we altered some of its amino acids, which results in insulin analogs, which results in proteins which were like insulin but has little different properties from the soluble insulin, from the human insulin. So these insulin analogs, in which some of the amino acids, like in this case the lysine, right, proline is replaced by the lysine and the lysine is replaced by the proline. So if such changes are made to the insulin protein, then these newer insulins were called as insulin analogs. So some of these analogs were rapid acting and some of these analogs were long acting. So the rapid acting insulins were are Lispro, Aspart and Glulisine, whereas the insulin analogs, insulin like molecules which were having a long duration of their action, are Galargin and Determere. So in short, we started with the insulin from the cattle and the pig, right? Then we mixed certain substances to the insulin which were called as NPH or isophene substances, and the insulins were called as NPH insulins or the isophene insulins, which used to work longer. Then we learned to manufacture the human insulin itself through recombinant DNA technology, and that human insulin there were some changes which was made to those human insulin, and as a result we got certain insulin analogs which were rapid acting, certain insulin analogs which were long acting. So three types of insulin we have. Number one is NPH or isophene insulin, right? Number two is the human insulin or the regular insulin, also called as soluble or neutral insulin, and the third one is insulin analogs. So the total types of insulin nowadays can be divided based on their action. So first insulin is rapid acting insulin, second category of insulin is short acting insulin, third category of insulin is intermediate acting insulin, and fourth category is long acting insulin. So this rapid acting insulin has a rapid action for 1 to 4 hours, whereas short acting insulin has a little more duration, 6 to 8 hours, and intermediate has 8 to 10 hours, and long acting has complete day and night. So the rapid acting insulins are Lispro, Aspart and Glucin. Short acting are the human insulin or the regular or the soluble or the neutral insulin. Intermediate acting insulins are the insulins in which this NPH is mixed. So they are called as NPH insulins or the isophane insulins. Then we have the long acting insulins. These are determier and glargine. So the short acting and the long acting are also called as insulin analogs, right? It is, yeah. Sorry, not the short acting, but the rapid acting and the long acting insulins are called as insulin analogs. Right, so once again, four categories of insulin: rapid acting, short acting, intermediate acting, and long acting. And one more thing, the rapid acting insulins, since they act, since they start acting within minutes, within 15 to 20 minutes, so you have to give them just prior to the meals or with the meals, right? Even immediately after the meals, they can also be given. Whereas the other types of insulin, short acting, intermediate acting, long acting, has to be given 30 minutes before meals. So the meal patterns in patients who are going to get insulin are divided into four patterns. They have to eat 4 times a day: morning food, afternoon food, evening food, and night or bedtime meal. The evening meal can be of evening snacks, and night dinner is a complete dinner time. The heavy part, the heavy meal, is night dinner. So now, what are the treatment plans for giving the insulin therapy? So just like oral antidiabetic agents, these are also given in once daily regimen, the twice daily regimen, or thrice plus daily regimen. That means once a day the insulin is given, twice daily regimen means twice a day regimen, twice a day insulin is given, and thrice plus means 3 or more times, to be precise, 4 times daily regimen is, when daily insulins are given, 4 injections are given. Right, the regimens keeps on increasing for once to twice to thrice based on the blood sugar targets and HbA1c targets. So once daily regimen, we will give the insulin injection only once in a daytime, and that daytime once in a daytime, and that time is generally before breakfast. At the starting of the day, we give this insulin, or if we want to give it in the dinner time, before dinner time, then we have to use long acting insulin. If we are giving it before breakfast, we have to give intermediate acting insulin. So this intermediate acting insulin, which is the NPH insulin or the isophane insulin, is given along with the oral antidiabetic drugs like metformin and sulfonylureas. However, the other antidiabetic drugs are discontinued when insulin is started. So the starting dose is 8 to 10 units or 0.2 units per kg, right? So 8 to 10 units it is started, and every 3 days it is increased by 2 units, right? After checking the blood sugar levels before breakfast. So we check the fasting blood sugars of the breakfast, right? In the breakfast we check the fasting blood sugars before the breakfast, and if they are not in control, they are not below 100, then we increase the insulin dose by 2 units every 3 days until they come normal, right? And if this regimen does not gives you the appropriate blood sugar levels, we change this regimen from once daily regimen to twice daily regimen. So the insulins which are given comes by these names, right? The insulin are the isophane insulin injections. See, isophane insulin injections, here also isophane insulin injections. The trade name is humoinsulin, human insulutard, and insugen N. N stands for NPH. Right. The companies are very few in the world which are manufacturing. These are the most famous companies: Novo Nordisk, the Lilly, and this Biocorp. There are others also, but Novo Nordisk has the maximum occupancy. Right. And if we are giving long-acting insulin, which can be given before breakfast or before dinner, only once, right? Either before breakfast or before dinner, right? So in that case, we will be using long-acting insulin, right? The insulin analogs like glargine and determere. So insulin glargine, like Lantus, is very common brand name. lentus or Basalog. So let us talk about the twice daily regimen. In twice daily regimens, there will be two injections which will be given to the patient, and these two injections will be given, one before breakfast and one before evening meal. Right. So two types of insulins can be used. One is pre-mixed short-acting insulins, and another one is pre-mixed rapid-acting insulin. So once again, the oral antidiabetic agents, sulfonylureas are discontinued. Only metformins are given, and the insulin doses are increased by 2 units. The starting dose is 6 to 10 units or zero point 0.2 units per kg, which is calculated, and it is divided into two doses, and it is equally given. If we are giving 6 to 10 units, that means 5 units. If we are giving 10 units, that means 5 units in the morning, 5 units in the afternoon, or in the evening meal. Right. So similarly, the increase also is done by 2 units every 3 days until blood sugar levels before lunch and evening meal are under control. And based on, and individually also they are increased. Like if only before lunch is increased, that means we'll increase only the breakfast time insulin, and if only evening meal is increased above the normal, then we will increase only the evening meal. So it can be different also, right? Different units in the morning, like let us say 8 units in the morning, and in the evening 4 units, like that. So let us take some examples. So for twice daily regimen, we have two types of insulins which can be used. These are called as pre-mixed insulins. So these pre-mixed insulins can be short acting, they can be rapid acting also. Now how? Let us talk about the pre-mixed insulins which are short acting. So these short acting, right? The human insulins and the insulin analogs. Pre-mixed short acting insulins, the human insulins, and the pre-mixed rapid acting insulins, which are the insulin analogs. So these human insulins, right, are pre-mixed. Pre-mixed means they are having two components, two insulins mixed in them. So what are these two components? One is the human insulin, right, which is also called as soluble insulin, and the second one is the isophane insulin or the NPH insulin. So these NPH insulins and the soluble insulins are mixed together and given. So they are mixed together in some ratio like 70-30 ratio or 50-50 ratio or 60-40 ratio, like that. So these pre-mixed insulins are called as biphasic insulins or mixed-tard, more commonly mixed-tard insulins. Like here human mixed-tard insulin. So these human insulins, right, soluble insulin plus isophane insulins are mixed together, and they are given in BD dose, in a morning before breakfast dose and in evening before evening meal dose. Another type of pre-mixed insulin which is given in twice daily regimen is the insulin analogs. The insulin analogs like aspart, glolicin. These short-acting insulins are also given, like here the short-acting insulin like Lispro, and this Lispro is of two types. One is simple insulin Lispro, and another one is insulin Lispro with protamine, that is neutral protamine hagedron suspension. So the 50% of the insulin works for a longer time, and 50% of the insulin Lispro works for a rapid time. So such type of regimens are given where either short acting insulins in a mixed dose are given, or intermediate acting insulins are given in a mixed dose, right? So biphasic, this is called as mixed start regimen, where either we uses human insulin, which is a short acting insulin, or we use a rapid acting insulin like Lispro. Now the thrice daily regimen, thrice plus daily regimen, we give 4 times insulin. So every time before breakfast, before dinner, before lunch, and before evening meal. So every meal is covered by insulin. So two types of insulin we use in such thrice plus daily regimen. One is basal insulin and one is bolus insulin. Now what is this basal and bolus insulin? The basal insulin can be any intermediate acting insulin or the long acting insulin. See, the basal bolus, it is also called as basal bolus regimen or basal plus regimen. So basal bolus regimen, basal bolus means food, every bolus, every food which goes into your mouth. And basal means at the base time. Base time means in the morning and in the night time. So basal bolus regimen, basal, this is called basal, right, which is given in the morning or in the night, and the bolus is which is given with every food you take. So basal insulin can be intermediate acting insulin or the long acting insulin, right? The basal insulin. So this basal insulin is taken either before breakfast, or if we are using long acting insulin, we can also take it before dinner also, right? So isophane insulins, which are intermediate acting insulins, or long acting insulins like insulin glargine. Right. So intermediate acting insulin before breakfast and long acting insulin before breakfast or before dinner. Apart from this, every other meal, that is the breakfast, lunch and evening meal, is covered by a rapid acting insulin. So rapid acting insulin or short acting insulin, any of these, right? Any one of these. So in rapid acting insulin, we use Lispro, we use Aspart, we use Glulicin, whereas in short acting insulin, we use the human insulin, right? The human insulin. So every meal, breakfast, lunch, and evening meal is covered by a rapid acting insulin or short acting insulin, whereas the dinner or the breakfast is covered by an intermediate or long acting insulin. These are some of the sites. We can give the insulin in the abdomen, we can give the insulin in the thighs and the upper arms, right? And generally we have to rotate the sites, right? If one day we are giving in the abdomen, then next day we have to give in the thigh, so as to minimize the lipoapotrophic changes in the body. And this insulin has to be injected at 90 degree to the skin subcutaneously. These are the references. Thank you.